Thank you, Reed. And although I'm starting with the challenges of AI, I have to say that I'm really excited about what our future is going to be. I am convinced that radiologists plus AI together, we're going to completely transform and disrupt the industry of what we're doing to provide better care for our patients. And ultimately, that's what it's all about. So I'm not the only one that believes this, that AI is going to help us transform the practice of medicine. Venture capital has spent literally billions of dollars in this investment on AI. So then the question is, you've got people that are really excited. It's a great technology. There's billions of dollars being spent on it. Why isn't it being deployed everywhere? We're going to talk through 7 reasons why. We'll go through one at a time. And I'll talk through the most common portions of each one. But again, I am really excited about this technology, and these are all things we can overcome. We just have to be aware of them. All right, number 1, the business case of AI. When we first started and AI vendors were coming to us and telling us, hey, you should buy our product, right? It costs money. There's not a lot of extra money to spend in healthcare. So what do? Well, the business case they came to us with was, we're going to replace radiologists. And that clearly doesn't work. We've proven that. Hopefully everyone has noticed that in the past 12 months. AI really doesn't have the ability to replace radiologists. It's not a good choice. AI plus RADs together are better than either one alone. Now, I will say that the vendors have recognized that, and they've started to change their business plan. They come to us now as a radiology practice, and they say, well, we can improve your efficiency. And that does have some business case for me. And to some point, I think the bigger area of a business use case is in how it benefits the hospitals and the patients. And so when they go to the hospitals, we're hearing them talk about increased reimbursement to the hospital, increased dollars coming in with more patients, and decreasing costs with decreasing length of stay and increasing ED throughput. All right, number 2, the maturity of AI. Even though we're starting to get a better business case, AI is really not that mature in the marketplace. So here's the Gartner hype cycle. Gartner is an information technology firm that is also a consulting firm that created this curve. And the curve talks about the maturity of any new technology within our space. And it is based on Amar's law. Amar's law is the fact that we tend to overestimate the effect of technology in the short run, and we underestimate its effect in the long run. So here's the curve with time on the x-axis and visibility of the product on the y-axis. The technology trigger in this case is artificial intelligence. And here's where Gartner and also I think that we are right now within the maturity of AI. We've come over the peak of inflated expectations where everyone said, oh, you're not going to need RADs anymore. And you can see now we actually need more RADs than we ever needed before. But we're starting to get into some negative press. And my suspicion is that over the next year or two, we are going to start consolidating in the industry. There are hundreds of AI vendors. There's over 100 FDA cleared products just in radiology. And those vendors are going to start consolidate as they realize they're not all getting the dollars that they need to pay back the venture capital that's got into it. So how do you choose the right vendor? It becomes hard when there's hundreds to pick from, but you don't know which ones are going to be around in the next year or two. Data. We know that artificial intelligence is extremely data hungry, and it doesn't need any kind of data. It needs structured data. And in radiology, all of our data is unstructured. And frankly, I don't know a lot of radiologists who have a lot of extra time or want to spend a whole bunch of time labeling examinations. And so it's really difficult to get the kind of data that AI needs. Now, the other thing is that we think our data is beautiful and it looks like this, when in fact our data is really messy. Our data is sitting in silos, there are proprietary components of it. Even though we have quote standards with ICOM and HL7, those standards you could really drive a truck through. And so it makes it very difficult to actually use all of the data, get it all in one place, and make sure things are normalized so that the AI can benefit from it. Bias and context. Hopefully you've heard a little bit about bias, and I could do a whole talk on bias. We only have a little bit of time, so I'm going to go through my 2 sort of favorite, and I think the 2 most important components of bias that I'm thinking about today. So here's, if you're going to remember anything from this session, I hope you remember this slide. There's something called sample bias, which is what causes the lack of generalizability of an AI algorithm. It's what causes what people call the brittleness of AI. When you think about a radiologist, we could walk from one hospital, go down the street to another hospital, read and interpret examinations from different workstations, different protocols without a problem. But if you try to do that with AI, it doesn't work. So why is that? It's because of what we call sample bias. If the training data is different from your data, then the accuracy of the algorithm is not going to be the same when it's applied to your own data in your own environment. So how could your data be different? Well, imagine if the study or the model was trained on a different level of magnet strength, 1.5 Tesla instead of 3. What if the CTs that they trained on were used at a different phase of contrast enhancement, so excretory phase? Or even here, it was only a few years ago where really everyone was getting oral contrast, and now very few people are getting oral contrast. So if the training data was on older data, then they're all going to have oral contrast, and if you use your data now, it probably doesn't. These things make a difference. There's a whole bunch of other areas that make a difference, whether it's about the data itself, the quality of the exam, the protocol, the scanner itself, or the patient population and the disease population. These are things that change over time. And so the accuracy that you hear from the vendor is the accuracy that they have done against their training data, their validation and test data. It may not be reflective of the accuracy in your institution. Here's the other component of bias that I think is really important to keep in mind, and it's automation bias. Automation bias is the fact that we as humans tend to trust automated systems almost more than we trust our own instincts. So this happened, this is a picture, it was really not hard to find. When GPS first came out, people were turning the wrong way down one-way streets, they were turning into parked vehicles, they were driving, in this case, into lakes. And when they were asked, hey, why did you do this? Why did you turn the wrong way down the street? They said, well, the GPS told me to do so. And it's not something to laugh at, it's something that's really important. We as humans naturally have a tendency to listen to an automated system. These AI systems are automated systems. It's really important for the radiologist to understand how it works because they're not always correct. And we can't just blindly trust the results of the AI system. So the implementation and the education that you do of your radiologist is really important to combat automation bias. All right, context. Now, AI does not understand context unless it's been told about the context. And here's an example. My husband's a huge sports fan. We live in San Diego, don't have any basketball in this area. So my husband wanted to get Clippers season tickets up for LA. He bought those season tickets, and then for a couple of months after, he was getting Google ads for hair clippers, right? A very different kind of clippers, but it's just a difference in context that the AI was not taught about, and so it might not know. The same thing happens with medical AI. All right, now the FDA is an organization that oversees a lot of our artificial intelligence products. These products are considered medical devices in many cases. And with that, they need to go through an FDA clearance. Now, the FDA is supposed to evaluate for safety, and it does a really good job of that. But one thing I want to make you aware of is while it is evaluating the quality of the algorithm, the accuracy of the algorithm, making sure that they've at least looked at a few different data sets, it's not evaluating how that algorithm is going to work in your environment. So here's an article that I found last year through the MIT Technology Review, and it was talking about Google's medical AI for diabetic retinopathy. And this is nothing against Google. They had a great AI system. In fact, it was super accurate in a lab, but real life was a different story. And when they went to deploy it, they were deploying it in Thailand. It was being used in ways that they just didn't expect. With different kind of users, not having the internet connections that they expected. There were so many things that were different than they were in the lab that it didn't function the same way. So what's really important is that you need to understand how the AI is going to work, not just on your data, but also in the context of your environment and the way that you and your radiologists work. All right, orchestration is one of my favorite subjects, and I'm going to show you what orchestration is. It's essentially the movement of data, and we absolutely need to move data when we're talking about AI. We need to either have a report if the AI is an NLP system, or we have an image if you're using computer vision. These have to get forwarded to the AI. The AI performs its function, and then they get forwarded somewhere else. Right now, that forward is usually to the radiologist through the PAC system or somehow into their workflow. So what is orchestration? Orchestration is the movement of the data. It is both of these arrows. Now, I'm only going to have time today to talk about the first part. So this is orchestration part one. It's how do you get your data to the AI system, and why is this important? And hope maybe in another time we can talk about part two. All right, let me go through some examples, and with these examples, we're going to learn 4 lessons about orchestrating your data. So why is it important? A friend of mine is a pediatric radiologist, and he told me about this great online AI model that evaluates a child radiograph for bone age. Now, just to let you know, no AI algorithms for bone age right now are FDA cleared, but there are some that are available and online, and this one won a competition, so a very good algorithm. I tested it out. I grabbed a left-hand PA radiograph of a child, and I sent it to the algorithm, and it gave me a great result. It gave me a predicted bone age, it gave me the gender, it can compare that to the chronologic age, and it did all of this in 1 second. Fantastic. And why was that result fantastic? Because it was an appropriate exam to send to the AI. It was a left-hand PA in a child. So what happens if you send something that's not appropriate? And in this case, wildly inappropriate. A mammogram, even flipped on end. I just grabbed this off the internet, said, what would happen if I sent this to my AI system? Well, the AI system evaluated it, and it told me that this patient was a 13-year-old male. Right? Completely invalid results because I sent it a poor modality, not even the right modality. If I knew that this was a mammogram, or if the AI system knew this was a mammogram, it would not have evaluated it. All right, is modality enough? No, actually, a lot of AI systems don't read the entire study. They will read one series of the study. In fact, for this intracranial hemorrhage algorithm, it's interpreting the axial series. So if I send it an axial series for this non-contrast head CT, it will appropriately tell me that on this study, there's no intracranial hemorrhage. But what if I sent it the sagittal image from the same exam? The false calcification is now in a different location. It may not recognize that this is false calcification. It may look at it and determine that it is hemorrhage. So you cannot send the wrong series. If I knew that this was a sagittal series and not the axial series that the algorithm was actually trained on, then I would not have sent it, or the AI should not have taken it. Okay, so right modality, right series, is that enough? No. Here is a patient. In this case, we've got a left-hand radiograph, and it is a PA radiograph, so all those things are correct, but in this case, it's an adult. So you can see there's arthritis. I send that to the algorithm, and yes, it interprets it again, and it tells me that the patient is 17 and a half years old. Clearly not right. This patient is around 70. It was an inappropriate exam to send. If the AI knew that this was an adult, it wouldn't have taken it to begin with. All right, last example, this is supposed to be a CTPA exam, right, for a pulmonary embolus, but you can see that the contrast opacification in the pulmonary artery is not optimal. It looks more like a CTA exam. Now, in our practice, we use 2 different algorithms to evaluate for PE. One is for a high quality exam, one that's meant to be a CTPA study, but a high quality one. That interprets and it looks for PE in exams that have high contrast opacification within the pulmonary arteries. Then we have another that is meant for sort of incidental PEs, where maybe you're doing a CT abdomen and pelvis or just a CT chest width, and it's not timed to be PE, or in this case, where it is timed poorly, and you don't have great contrast opacification of the pulmonary arteries. Why do we do that? Because if you train it on a smaller set, you can get better accuracies than have one that's generalizable to both. But if the study comes across as a, quote, CTPA, it's immediately going to go to the high quality PE algorithm. And so you're going to get lesser quality results. Wouldn't it be better if we knew that the study had lower contrast opacification of the pulmonary arteries? Because in that case, we would make a better choice and we would send it to the incidental PE algorithm and get a better accuracy. So what have we learned from orchestration? We learned 4 lessons. We need to send the right series of the right study for the right patient to the right AI model. And that requires some work. It's not automatic just based on your DICOM header or different tags. And all of this, although there are difficulties, and I mentioned 7 of them, that seems like a lot, and there's even a few more that I didn't mention. Even though they seem like difficulties, these are all things we can overcome. And I believe very strongly that together, if AI is working with the radiologist, if we have human cybernetic collaboration and practice or academic center with vendor collaboration, we can overcome all of these and really transform the practice of radiology and medicine. All right, so let's get back to some of the possibilities of AI and talk about where can they be used. So when you think about where AI can be used in radiology, radiology is too big of a space to think of it as on its own. It is much easier to split up the components of radiology into what we call the life cycle of an examination. From the moment that a referring clinician has a clinical question, they want to order a study, all the way through the acquisition, the interpretation, the follow-up and peer learning, every single segment of this can be optimized with artificial intelligence, and in fact, it is. So here's examples being used today, and many of them are in fact FDA cleared. There's even uses of artificial intelligence within the workflow that lies completely outside of it, and frankly, it's an area I'm really excited about. But what I'm going to talk to you today for the examples are the most common use right now of artificial intelligence. It requires the least amount of regulatory oversight, and that is CAD-T. So what is CAD-T? CAD-T is a triage model. Triage models are essentially a detection model where you detect the AI uses computer vision, and it will detect a certain thing, usually a pathologic finding. That pathologic and often critical finding is then communicated with your work list. The work list is then aware of where there are pathologic findings. It alerts the radiologist, and hopefully the work list can then reorder the study. Now, this on its own is actually fairly exciting. When you think about how Reed talked about radiology in the 90s, even though we've digitized radiology, our work lists have not changed that much. When I first started reading, I had a stack of radiographs that I had to go through. And I would just go through them in the opposite order they were received. I read the oldest one first. Well, digitized work lists are very similar. We read the oldest one first. Yes, we add in some SLA agreements. Yes, we add in some prioritization, but we don't know what the pathology is. You don't know anything about what is in the image until a physician looks at it. But with artificial intelligence, you can get that information in advance. So all of that pathology can come to the top of your work list. Now, this may not make a huge difference for your stat cases where you're reading them maybe in 15 minutes already, certainly for a stroke case. However, it should have a bigger effect on your outpatient imaging and even your inpatient. Some inpatient studies aren't read for an hour or even 4 hours. You can fast forward that and make sure that they get taken care of more quickly. All right, so is that it? There is more, and we ran a 6-month pilot back in our practice using 2 different CAD triage models, one for intracranial hemorrhage and one for PE. And we found not only did it allow us to get to the pathologic findings faster, it actually helped us improve detection, right? We're human, we miss things, we know that. AI misses things too, but AI and radiologists together can detect more than either one can alone. So in intracranial hemorrhage, we found that with AI, we were detecting 2.4% additional findings, and with PE, 4.4% additional findings. And the images on the bottom are actual findings that the radiologist initially missed that the AI picked up. And you can see that both of these cases are pretty subtle, and we did tend to see that the cases that the radiologists were missing were fairly subtle. And it raises the question of, well, does it matter? Could we ignore subtle findings? I mean, that may sound ridiculous, but you could imagine, do we know that subtle findings really drive value? what if we treated all of these patients with subsegmental PEs and you had more complications than you ended up having for a benefit? Or what if you brought in all of these patients with these super tiny hemorrhages? You may add more cost to the system. And I think we're going to find a lot more as we start to use AI more, but I will tell you already anecdotally that we know that that's not the case, that some of these even super subtle findings are really important. So here's an example. This was a 72-year-old patient who came in with altered mental status. They came into one of our emergency departments. The study was read as chronic findings, right, initially called essentially negative. But the AI picked up a really subtle, small acute subdural hematoma sitting along the left aspect of the calvarium. And so we called this patient back in. When they came in, it was 36 hours later, and in that time, the hemorrhage increased significantly. Now, this was not a patient that had trauma. They came in with altered mental status. This was not a patient who was on Coumadin, but yet this really tiny hemorrhage increased significantly, so much so that it was causing mass effect on the brain, compressing the left lateral ventricle and causing left to right midline shift. The patient actually required a craniotomy. They needed surgical decompression. And so we can't just ignore, even though a finding looks really subtle, it may turn into something big. And over time, the more of these we figure out, especially if we combine it with data from the EMR, we'll be able to say, yeah, this is a patient that you probably should keep in-house because they are at higher risk for developing a larger hemorrhage. And this is a patient that maybe you could send home. All right, so is there opportunity for improvement just for intracranial hemorrhage and PE? No, there are opportunities for improvement really everywhere. Published miss rates are generally up to, in the 10%-ish range, but up to 40% in some cases. And when you're talking about an incidental PE, what do I mean by incidental? One that we're not expecting. So a PE that's sitting in the lung bases when you're doing a trauma study for CT abdomen pelvis with contrast. Radiologists tend to miss those even more frequently. But if you add AI with that, the radiologist plus the AI can improve significantly.